Welcome, everybody. So glad to have you all joining us. We are here and want to invite you to join with me in a land acknowledgement. You can join in the chat and acknowledge the name of where you are located. At the bottom right, you'll see placenames.mathdev.ca, which helps you see the specific location of where you are and even how to pronounce it. So let's take a deep breath and acknowledge the specific location where we are located. I live and work in MAiD. This is located on the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the peace and friendship treaties that were signed with the Mi'kmaq, Maliseet, and Passamaquoddy peoples from 1725 to 1779. This series of treaties did not surrender Indigenous land, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act in 1982, and they remain active to this day. Let us take this time to pause in reflection and gratitude for the land where we live and work. The Nova Scotia College of Social Workers commits to translating this acknowledgement into action. By seeking to implement the recommendations of the Truth and Reconciliation Commission's calls to action, especially those regarding education, we commit to doing what we can to becoming better treaty partners. We commit to learning and unlearning. Let us take this moment to pause in gratitude for all who have and continue to heroically care and advocate for this beautiful land. May we join them in this sacred work. Let us ground ourselves in the wisdom of the land-based Mi'kmaq teachings and values that we must all begin to learn. Let us work to decolonize ourselves, our practice, and this community that we share by working for justice for all living beings as an expression of our gratitude for being here. Let us take a deep breath and recenter ourselves away from the violent ways colonization fills our world and fills us. Let us take a deep breath and work on letting go of the unconscious bias that is everywhere, inside and out. May our session today lead us to be in right relationship with this land and with one another. When we acknowledge the land, we must also begin to acknowledge the wisdom of this planet and align ourselves with its truths. Today we begin, and I'm going to stop sharing and introduce Annette and Marika. Dr. Marika Warren we'll hear from in a little bit, that is with the Nova Scotia Health Ethics Network, and I'm so grateful to have her joining us. And we will begin with one of our own, Annette Sampson, who is a social worker and works with MAiD within the MAiD department. And I'll let actually Annette introduce herself probably better than I can. But Annette is going to start us off just explaining a little bit about medical assistance in dying, and then we will have a conversation about ethical concerns and opportunities.
So thank you for inviting me, Naj, to participate. I think this is going to be a very important conversation going into the future in terms of looking at our access to resources, thinking about our ethics, and as social workers, the moral distress that we might have in light of the changes to federal MAiD legislation in Canada. So briefly, my name is Annette Sampson, and I've been an acute healthcare social worker, both in emergency mental health at the IWK and also in medicine at the Halifax Infirmary. So it's been about 16 plus years. Prior to that, I worked with at-risk youth here and in Toronto, and in seniors mental health in Montreal. But since the middle of March, I've been one of the social workers on the province's access and resource team for medical assistance in dying. So I've been kicking around here since March and trying to find my way and sort my way through things. I'm just going to share with you a little bit about where we came from in 2016 to where we are now in terms of legislation as it pertains to Nova Scotians. So yeah. So right now we have 2 tracks to medical assistance in dying in Canada. That is those who are expecting a reasonably foreseeable death. And then we have a second track right now, and that's those whose death is not reasonably foreseeable, but they're suffering from a serious and irremediable medical condition. So that's kind of important to note. So since 2016, then that change happened in 2021. And now we're looking at another change in March of 2024. And that's pertinent to the conversation I think we're going to have today, although it's been an issue ongoing since. And that is in March of 2024, MAiD is going to expand to include mental disorders as the sole underlying medical condition. So some points in my little conversation here, I'm going to say MD-SUMC or MDSUMC for short, because mental disorders as the sole underlying medical condition is a bit of a mouthful. So MDSUMC for short. So in March, we expect that we're going to get lots of requests for medical assistance in dying from this third track. So data from other countries providing MAiD to folks with mental disorders. It would suggest that Nova Scotia will have a fair uptake of requests at first in March. And in fact, we're receiving lots of calls from people who believe that they are eligible now, are eligible to make a referral. But in light of these impending changes, a working group has been convening here in Nova Scotia that predates me. I think Marika Warren, Dr. Warren, has been involved much longer than I have in this group, but I'm involved now. And the group that's convening around this new legislation is seeking to address those changes in federal legislation so that those seeking a MAiD death for reasons of mental disorder will be screened appropriately for eligibility, but also that they can be supported throughout the process, because it will be a lengthy process of determining eligibility. So to backtrack a little bit, I just wanted to explain that in 2016, there was one person who was overseeing all of the MAiD requests and coordinating all of the assessments that needed to happen for MAiD. So about 1 to 2 years ago, MAiD consisted of a team lead, a nurse navigator, and a 0.1 medical director. And I believe they had hired a nurse practitioner. So from that kind of skeleton crew, where we are today is we have 4.5 nurse navigators. So nurse navigators are the first point of contact for folks. They will call people who have left messages on the MAiD voicemail, or have made inquiries, or doctors who've referred patients to the service. So that's 4.5 nurse navigators from one. And one of those nurse navigators is going to be a dedicated nurse navigator for the MD-SUMC group. 3 nurse practitioners. So nurse practitioners are able to make assessments, and also they can be providers of MAiD as well. We've also expanded to 2 social workers this year. And we will be working with the nurse navigator as well to help gather information, but also provide support to the folks who are seeking MAiD for reasons, for mental health reasons. Also, we are going to have another 0.1 MD-SUMC medical director. So right now we have a medical director who is 0.1, and we're kind of going to double that to another 0.1 MD-SUMC for mental health folk. We also have a clerk and a client services manager. So we have increased exponentially in order to address the ongoing increase in need for MAiD in their province. The other thing I wanted to talk about a little bit is that oh, wait 1 sec. I think I have, nope, data. So in 2016, we had 36 referrals to MAiD. So from 2016 to 2022, that number increased, those referrals, to 684. And projections right now are that we'll be over 700 for 2023. We have no way to predict what 2024 is going to be because of the MD-SUMC referrals, but we suspect it will increase even more. So there is that. So the group that is convening to look at those impending changes that kind of predates me, we're looking to address the gravity of those changes. So that's going to mean a lot to our community. People with mental health concerns being eligible for MAiD. It's going to mean a lot for the practitioners in the community who are trying really hard right now to address the needs of folks in our community who are trying hard to live with dignity, as well as, you know, maybe they're homeless, they may have lack of access to mental health resources. So those folks are going to need to be supported through the process of applying for MAiD, even prior to eligibility. Yeah. So there's where that group that has convened is working on a screening tool that will look at eligibility and support for the folks who are seeking MAiD. I have to say that as social workers, we're not unfamiliar with moral distress in our professions, and that there's some new federal legislation. This new federal legislation is going to be even more challenging to that. And we know that our healthcare system is troubled, and that our social supports are stretched. So how do we provide care that is appropriate for all and avoid people jumping the queue, which some people have suggested might be a good idea, when resources are so stretched. And so more resources have been promised by the federal and provincial governments. Those have been, as we all know, a bit slow in happening. But I think it's important for us as social workers. We're going to be getting questions from people in the community. Well, should I ask for MAiD? What should I do? How should I proceed? And this is going to pose some ethical dilemmas for us. I think it's important for us to have conversations about that. It's also going to be important for us to know where we stand as social workers within MAiD legislation. And the college has outlined and has done quite a bit of work in sorting out what our role is in MAiD going forward, and where we have a place and where we need to refer to experts. So in light of that, also, I just wanted to, I'm not sure if anybody has heard about this situation, but it's something to sort of think about. And I think it really speaks to the distress that some social workers in the community are probably feeling already around MAiD. Just 2 weeks ago, it was reported that someone in BC who presented to the emergency room in a mental health crisis. It was suggested to her that by a social worker, had she considered MAiD. So I think we all know that that was not an appropriate response to someone who was seeking support to live through her mental health crisis. However, I think it's important to see that in the context of what was that social worker experiencing, what kind of distress was she experiencing, or he, I'm not sure who the social worker was, when suggesting quite inappropriately, have you thought about MAiD? I think it's going to be important for us to familiarize ourselves with the legislation. First of all, it is illegal to offer MAiD to anyone right now who has a mental health concern. That legislation isn't coming to effect for another year. And second of all, maybe we need to think a little bit too about how we are supporting ourselves around some of these questions. And there is also something that we need to think about in terms of advocating for people in our community. And there is definitely a part for us to play in advocacy for support and for resources in our community. I'm sorry if I've gone over time, but I just wanted to kind of put all of that out there.
Yeah. So a reminder to everyone that it is outside of the scope of practice of social workers to be offering MAiD. So I am going to now share my screen. And we did not, we had already planned this lunch and learn before this situation happened, but it is a reminder to everyone. So if you can see here, I'm sorry, I'm trying to show my screen again, but if you can see here are, and I put the link also in our panel, but if you can see how our guidelines are very clear, that's what social workers can and can't do. Sorry. So we should not be suggesting MAiD, but we can support MAiD. We have a comprehensive set of guidelines on our website, and I put the link there. But when we think about what happened and the social worker who suggested MAiD, we can see, first of all, the moral distress that may have happened to cause the person to make that suggestion, because there are very few resources out there. And we can also understand how sometimes with this expansion, there's going to be even more ethical challenges. If it's harder for a person to get an appointment with a doctor or a therapist or a psychiatrist in order to help them live, if it's harder for them to find affordable housing than it is for them to get an appointment with MAiD, then the appointment to MAiD becomes the easier option for folks. And that, of course, raises large amounts of ethical concerns, not necessarily with the social work code of ethics, but with ethics more broadly, which is why I'm so grateful that Dr. Marika Brown Marika Warren is here from the Nova Scotia Health Ethics Network, because we need to be making ethics consults within the healthcare system when there are situations like this, rather than us feeling like we're on our own to try to deal with this, which causes our own moral distress. Please reach out to the college. We are here to help you. So when social workers experience moral distress, an ethics consult to us and an ethics consult to the Nova Scotia Health Ethics Network and advocacy for the larger structural issues can help us turn challenges into opportunities. And so when we are thinking about medical assistance in dying, the current situation, as well as what may come into practice when in 2024, when MAiD is expanded to allow non-fatal situations. So right now, medical assistance in dying is only available if a person has what is considered a fatal illness. So mental health concerns are not currently included in that, but they will be expanded to include that. And if you haven't seen, we did a 3-part education on medical assistance in dying and ethics that looks at how that expansion happened. So that is something worth looking at. However, there will be times even now where MAiD is suggested that may cause an ethics concern. So we are going to be doing a little case study. Many of you may remember Tristan, who spoke at our Advocacy Day in 2023, and who also spoke at our annual conference. And he has given us permission to share this video that was part of Advocacy Day 2023 to look at some of the concerns. So we're going to have a chance to hear from him that he was living in Nova Scotia, had a very rare neurological condition, and because of a variety of other intersectional issues, as someone who identifies as transgender with some mental health and addiction history, who was homeless for a while, who then was able to get into housing and resources, who tried to access support for progressive neurological disease that is rare. And he was not able to get the medical care that he needed. And the only thing that was suggested to him was MAiD. He then went to Alberta, where he was able to get medical assistance to live, and was able to be in the hospital. In fact, he filmed this while he was in the hospital, and he is going to talk a little bit. He now is living independently in Alberta, and will share a little more about his story. But this is an example of a situation that some of us might be aware of in our work with people that should be an ethics consult, both to the college and to Nova Scotia Health Ethics Network, so that we can begin to discuss how we can transform this into advocacy for structural change. But let's hear and ground ourselves in his first voice experience. And then we will turn it over to Dr. Warren so that we can discuss the different ethical concerns, implications, and what social workers and other healthcare providers should do, can do, as we begin to think about our commitment to social justice.
Hi, my name is Tristan. Thanks for inviting me to speak at this event. It's really great to see more conversations shifting to action. As the title suggests, I recently moved, so it's been a pretty hectic time, but somehow feel so relieved to be somewhere I know I won't die if I need urgent care, and have hope that things can get better, or at least that it won't keep getting worse without any social safety net. Although I didn't realize how close I was to homelessness with moving, I still feel safer here, and at least less like I've just given up and accepted the way things were. So I guess even if I'm not objectively safer, the sense of security in a social safety net is worth more to me. The decision for me came.
I do want to just specify, he first was homeless in Alberta, but then was able to access resources. So now he is in an apartment, but this was filmed last year.
down to accepting that I couldn't change the system and there were no alternative care options, and realizing I could change how I respond. So instead of the insanity of trying over and over to get care from a system that's maxed out and unable to help, I could choose to leave. Although moving was my choice, it's a choices we make depends on choices we have sort of situation. So when every other choice is gone, is it really my choice? Definitely glad I got pushed to move regardless of why. It's nice to see different ways life can be. It reminds me of my youth when I stayed in some harmful situations to avoid going to a shelter, believing anything was better than shelters, then finally going and regretting not trying sooner because the shelter and sleeping outside was way better. One of the final push factors in leaving NS was learning there were no neuromuscular specialists left in NS besides the one who called me crazy and rejected further referrals. Earlier in this journey, before the push factors stacked too high, I thought medical assistance in dying was a way to access services as a backup plan, because it required a specialist in my condition to see me, although I've learned that isn't really what happens from listening to other people's experiences. Then over time, because I didn't have support to live and didn't have healthcare to stop needing so much support, legitimately pursuing MAiD became the only clear option left in Nova Scotia. It wasn't that I don't meet criteria for services to live, or that my health issues and disabilities aren't real. It was that in Nova Scotia my needs were nothing compared to the abhorrent conditions other disabled people and seniors live in. The unacceptability of others' conditions didn't make mine acceptable, and it didn't reassure me hearing that well, it's not that bad, because you aren't totally paralyzed, or because you don't choke to death constantly, or because you can still breathe. And it definitely didn't reassure me hearing stories about people whose situation is worse and how even they don't have access to support, because I kept getting worse and everyone kept saying it's not that bad compared to a moving target of increasingly worse comparisons. Like at first it was we'll take you serious when it progresses to both sides of your body. That happened. Then it was if it had visible signs. It does. Then it was if it makes you dependent on other people. It has. At this rate I knew I'd die before Nova Scotia Health, Disability Support Program, or Continuing Care would even look at me. I thought that was pessimistic, but I moved across the country and am effectively homeless, and they just went good luck, thank God we don't have to do anything because we can't. It's not that healthcare professionals and social workers didn't care. It's just their perspective, and the perspective of many Nova Scotians is based on a reality where only people completely incapacitated or half-dead might receive services. The plans to fix healthcare through more access to primary care is a good long-term and preventative plan, but NS isn't in a preventable situation anymore, it's not even in a reactive situation. If you look on the Action for Health site with database of who goes to emergency rooms, you'll see oftentimes at least a third, if not half of the people in ERs are literally dying or almost dying. So Nova Scotians have had a lack of care for so long and so few specialists and social services options, that most of the resources are going to reactive responses, and really something past reactive, because services don't happen until too late. It's not providers' fault that such under-resourced and understaffed services aren't working. A lot of great people somehow keep trying to help, but no amount of caring or advocacy will make more resources appear. Advocating is good for situations caused by issues with resource allocation, awareness of needs, and making a case for why something needs to change. Advocacy is not very effective without things to advocate for or people to advocate to. This is true regardless of one's quote-unquote effective advocacy skills. It's terrifying that I couldn't find resources or access services I needed to live in NS because I'm aware of more resources than any social workers I've met, and that wasn't a good thing or an asset. Knowing that I exhausted every resource and then some, tried every back door and even built some new ones, and to have that still just go in circles to nowhere. I wish anyone could have told me I didn't know about all the options, that I still had hope in Nova Scotia. I built a really amazing life there. It's by the longest I've lived anywhere, and as a place Halifax and NS were perfect for me, and there's so many amazing and caring people. After spiraling for a while, everything came full circle, learning that only one neuromuscular neurologist still works in NS, and it's the one who called me crazy, and I need a neurologist to run a blood test that costs too much for non-neurologists to run, and NS doesn't have private options to pursue certain autoimmune and genetic testing. It's been interesting talking to service providers in Alberta, realizing how much perceptions of what services someone needs or the quality of life they deserve is tied to what actually exists there. I think the gaslighting in NS was just the only way people working in health and social services could make constantly witnessing unacceptable situations bearable enough to keep going. That said, there are legitimate issues with cult-like beliefs among some specialties in Nova Scotia's healthcare system. After asking questions about rationale for conclusions about my case, I learned these psychosomatization beliefs are passed down to residents and spread across specialties. I think I came to the root of the issue with a Nova Scotia health psychiatrist, and no, I didn't find the root cause by uncovering my suppressed emotions. I mean, this doctor literally wrote the book on stereotypes and misappropriated diagnoses. I acknowledge the evidence that stress and ignoring needs make situations worse. Stress isn't just emotional, it's systemic and can be things like inadequate nutrition, social isolation, poverty, inflammation, and secondary illnesses and injuries, and emotions are just one of many potential stressors. But medicine is not certain enough to accept emotional stress as the sole contributor without evidence or positive signs for that conclusion, and attributing all of someone's health issues to emotions without any reason besides mental illness is not medicine. Although it would be simple to say, well, misconceptions held by neurologists is caused by this quote-unquote medically unexplained symptoms doctor who misguided them, I think it's more likely a co-signing of BS. I was sent in circles back and forth between neuro and psych, with neuro saying it's suppressed emotions, then psych saying my mental health is good and my feelings about lack of care were rational. I know I was shocked too, only to have neuro tell me again it's suppressed emotions, then send me to the specialist in this gaslighting tactic. Again, it would be simple to say it's just some bad specialists because NS doesn't pay as well. But if I've learned anything through all this, it's that even my suspicions give more benefit of the doubt than the reality deserves. Medical gaslighting feels the same as emotional abuse, where it slowly got into my head, making me question myself and my beliefs. Although having experienced enough abuse and manipulation in the past, I was quick to recognize the danger of allowing such manipulations to infect my mind, and able to question the evidence behind their statements. That said, nobody's invincible, and even more importantly, I shouldn't need to pretend to be inhumanly strong in order to survive, much less to survive the people and systems supposedly built to care. The codependent relationship built on this care is dangerous and harmful. I questioned my sanity even though I do so much work to maintain my sanity and know how obvious it is when I have active mental illness, yet I still began to doubt myself. This systematic mechanism for rejecting people with rare or just complex conditions is not just some bad professionals, it's a system that demands it.
So here is Tristan, and he has given us permission to share his story as a case study, but we may have other case studies of people that we are aware of. So when we think of this issue of medical assistance in dying and possible ethics concerns, we may have issues that are coming up now. We are likely, as Annette said, going to have more issues as MAiD is expanded in the coming year to include non-fatal illnesses. We see that the requests have grown, and it comes, that growth of requests comes with ethical concerns. So know that you are not alone, know that there's resources that exist, but let's now have a chance to meet with Dr. Marika Warren, and Dr. Warren is going to help us begin a conversation about health ethics and what concerns will be raised for us to be thinking about. How would a health ethics consult deal with a situation like that? Let's say, for example, I was the social worker working with let's say I was the social worker working with Tristan, and I listened to this story and I was like, oh my gosh, this is wrong. What is happening? I have this ethical concern. I reached out to the college and the college said yes. And there is nothing about the code of ethics of social workers that we can help you with, but because we're colonized, everything is in little silos. So what I used to do with our ethics consults is what the college used to do is say, oh, well, you're right, there's nothing that we can help you with. Now we have a partnership, so we can bring all the disciplines together to look from a health ethics perspective in a more comprehensive way. So what happens if we make an ethics consult, and then what can we begin doing to look at the structural change that is a much larger decolonizing goal?
Great, thank you. Pardon me. Thank you so much, Naj, Annette, to Tristan in absentia for sharing his experience. And so in the time that I have, I'm going to try and keep it pretty brief so we do have some time for discussion. But just to give you a sense of what an ethics consult might look like if you, as a social worker involved in a case like Tristan's, came and brought it to NSCN for discussion. So we've, in previous ethics cafes, we've talked about that sort of process. And so you can look back on that. But in terms of sort of what to expect, it would depend on the specific question, specific concern that was being brought. So whether it's perhaps a way to deal with the moral distress that a case like this engenders, in terms of the sense that I think came through in Tristan's narrative, as well as in the example of the social worker that Annette mentioned in Vancouver, of wanting to help, feeling that sense of, if only I was able to access resources, we could help a person in this way, and feeling that you're put in a position where you're the only thing you have is something that you feel is inappropriate and inadequate to really meet the concerns that are being brought forward. There might also be a need for, as Naj mentioned, that sort of broader systemic advocacy. So a lot of the discussion that has been going on in the MAiD MDSUMC working group that Annette mentioned that I'm part of, is really looking at processes for tracking, for review, and having sort of multiple places where we're getting that information. So with the Nova Scotia Health Ethics Network, we do track the topics that are sort of at the root of the ethics consults that we receive, and we feed those back up through to senior leadership at Nova Scotia Health, or if as appropriate, IWK Health or Department of Health and Wellness, in cases where those collaborating partners have concerns. And then also through the work of the working group that Annette mentioned, is looking to support the MAiD team who are seeing these cases, gathering the information that we need in order to identify those cases where concerns about things such as capacity, vulnerability, and suicidality, which have been really a big focus of the discussion on that working group, are potentially affecting people's choices, such that, like Tristan, if they had other options, if these factors weren't at play, they might choose differently. And certainly these things have been really highlighted by the discussion around MAiD MDSUMC. But from my perspective, they still apply across the board. Whether or not someone's wish to access MAiD stems from a condition where death is reasonably foreseeable, which is the language of the law, or whether it's a death that's not reasonably foreseeable, but nonetheless it doesn't stem from a mental disorder. So that's the sort of track 2 cases that Annette was mentioning as well. That any case where we are worried that the decision doesn't reflect sort of what the person would make in sort of the best or a better scenario, where we have those sort of systemic concerns that vulnerability, structural injustice is really motivating action, that we're able to track those and again identify these as issues that need to be addressed on that sort of broad systems level. So there's sort of a 2-layer response often that we'll have. So one is trying to help folks to recognize that the distress that they're experiencing is appropriate to the situation that they're in, and actually reflects a moral resilience and a moral healthiness, that you're able to still appreciate this as a situation where there are some ethical harms potentially occurring, as opposed to being, as it sounded like in some of Tristan's narrative, so burnt out by the constant ways that systemic pressures have eroded you, that you're no longer sort of sensitive to or aware of the sort of ethics concerns. Another piece of those conversations that we have around MAiD from the ethics perspective is really to recognize that sort of from the get-go, back in from the Rodriguez case onward, there have been significant ethical and values dimensions to the Canadian experience of MAiD, and that our legislation is grounded in a balancing of a number of values, including respect for autonomy, trying to provide the best possible care, avoiding unnecessary harms, justice, including equity, importantly, professional integrity, relationships, trust, and accountability, and that we're always, in any case, trying to find a balance of all those values that's appropriate to the situation and to the individuals and communities who are involved, but also recognizing that there are no trump cards in these discussions, and that the particulars of the situation are going to matter significantly. Some of the concerns that Tristan raises are ones that we've grappled with in healthcare generally for a while, in terms of the disparities in resources available. So both between provinces, certainly as the differences between Alberta and Nova Scotia that Tristan flagged illustrate. And as someone who grew up in Alberta and still has family there, so there are times when I feel acutely aware of some of those disparities in healthcare systems, and again, also with other places, but even within provinces. So, for example, folks who in Alberta who live in the urban centers get very different sorts of access to care and resources than those who live in northern, remote, often Indigenous communities. And so those disparities are always part of the discussion and have been part of the MAiD discussion from those sort of early cases. There was some concern, for example, by patients who had ALS and needed more resources and supports than their community was able to offer. So even though they didn't have a condition that made their death reasonably foreseeable, they were nonetheless choosing to access MAiD earlier than they would have otherwise because of those lack of resources in their community, and not wanting to leave their community and their families at that critical end of life period in order to access resources. So these are some questions that we're grappling with in a number of different places, and that have really had a spotlight shone on them by some of the discussions around MAiD, MD, SUMC. So again, access to psychiatry, for example, being a significant one of those. And in the case that, again, of Tristan, the fact that he wasn't able to access a second opinion, again, raises those same sorts of concerns. Similarly, with when MAiD came in 2016, there were concerns around disparities in access to palliative care. So again, all of these things come into our questions and concerns. And as the Nova Scotia Health Ethics Network, we see our role both as, again, providing supports to those individuals on the ground with the intensely ethical concerns that they're having in their practice, but also to use where we have access to senior leaderships to channel those concerns up to provide some of the numbers that we do from tracking our consults to be able to say we're seeing more and more of these sorts of concerns. The only way to address them is at that sort of broader systemic level. How can we support you in your leadership role in bringing those ethics lenses to the decisions that are being made, and sort of seeing that system as a whole and seeing where the burdens and benefits are being distributed and to whom. So I think I'm going to stop there just in order to open up the time for conversations. It looks like things are headed into the chat. So I'll turn it over to you, Naj, to moderate that discussion, unless there are specific questions based on anything that I've said where people really want some clarification of any of the details.
Yeah, thank you so much. And this is much larger, and even like, Dr. Warren talked about escalating up within the healthcare system. So there's really multiple tracks, right? There's an internal and an external. So people can contact us, we can contact people back to escalate and have multiple disciplines that are all around the same table, looking at the health ethics and escalating those concerns within the healthcare system. But there's still a lot of work around bringing together health and the structural health pieces. So that's where we want to be working with Nova Scotia Health when there are structural advocacy issues, to contact us back for our social justice committee to then step in. And then we are working with the Doctors Nova Scotia, with the Association of Psychologists, occupational therapists. We are working with growing interprofessional health team to advocate cohesively the way we did, for example, with the protecting queer kids in the school. We want to do that with other structural issues so that all healthcare providers have an outlet for their moral distress and advocate at the same time at our next advocacy day, that we have all of us joining together to say, we cannot be divided. We are all united in advocating using our toolkit to try to build awareness for funding, for resources. There's a new program that Nova Scotia Health is piloting called social prescribing. So stay tuned, more information about that. But social prescribing is where maybe a doctor would prescribe a portable house, apartment, that's what is actually needed. So it's redesigning healthcare to think beyond the biomedical, beyond even the psychosocial, to look at the structural and spiritual and funding. And we need to be working together to put all of these pieces back together. So it's an exciting time. We will take questions now. I am going to ask, there is one question that was already put in, and it was, I'm going to throw it over to Annette. The question was specifically about what type of mental health conditions will be considered for MAiD. So Annette, I don't know if you or Dr. Warren can answer that, and feel free to put everyone else questions in the chat.
Sure. What I can say about that is that what it doesn't include in some ways, right? So the folks who are being referred for reasons of mental disability are people who they cannot have a neurocognitive issue or a neurodevelopmental disorder. So that would include your folks with dementia. The only criteria right now is that the mental disorder needs to be resistant to medical treatment. So if someone has an irremediable condition, very similar to the track 2 patients, an irremediable condition that is primarily a mental health issue, then it needs to be treatment resistant. And there is a process that we are sorting out in ways to sort out whether it is actually treatment resistant, if there are other treatments that can be applied to this person's mental disorder. So, if someone has depression that is resistant to treatment, they would be considered a candidate for medical assistance in dying if they pass their assessments and all was right with the world. But definitely capacity continues to be important in all spheres. So people have to have the capacity, the ability to consent to this treatment. So if someone is actively ill, that might affect their capacity. So they might not be able to consent to MAiD at that point. Does that answer the question? I hope so.
So it does. And the question then is, how is treatment resistance being defined? And and depression can affect our capacity to make a decision, which is also true. But treatment resistant is really the bulk of this issue, because what is considered treatment resistant? For example, if the current best practice for depression, let's take an example, is somehow cognitive behavioral therapy related. And we happen to know from a research perspective that people with neurodiversity actually experience harm through cognitive behavioral therapy. But that is the treatment that is being provided. Then we see that there's a deep ethical mandate to expand treatment options to include other evidence-based or non-evidence-based, but culturally appropriate ways of dealing with therapeutic options. So it becomes very complex. What is treatment resistant? What are the other resources? Is there funding around income, housing? What constitutes treatment? That's where the social prescribing that's just starting, right? We are in such a unique place. So there's a lot around that. Okay, so we have a question about what if a person has designated a statutory decision maker in the event that they lose capacity? So that is something, and I do want to say that Dr. Warren has said there are plans to put together some education resources that will include ethics concerns. You are cutting edge right now having this conversation, but it's very important. So yes, please.
So I think I can answer to that. Right now, no one can consent to a MAiD treatment except for the person who is meant to be receiving MAiD. So even if you're track 1, if you're track 2, now new MDS-UMC folks, everyone needs to consent to their own MAiD procedure. So yeah, unfortunately, well, fortunately, no one can consent for MAiD on your behalf. You make a really good point, Naj, about depression, and that sometimes that can affect your capacity. Absolutely, it can. And so people who are actively depressed, actively, and those folks, their capacity will be called into question, right? So that is gonna take some doing in order to figure that out. And everybody who applies for MAiD under the MDS-UMC provision for MAiD, none of those referrals will be taken lightly. So there are, the referral process and also the assessment process. So in order to receive MAiD, you have to go through assessments with 2 different practitioners. But with MDS-UMC, there's also going to be an expert. We need an expert to weigh in on the referral to MAiD for these folks as well. And then also a greater discussion amongst several people. So it's going to be a little more rigorous than, say, someone with a reasonably foreseeable death.
I think just to build on what Annette mentioned there is that, and to link to your earlier points, Naj, that process is also going to include capturing the structural vulnerabilities explicitly, both so that those can be tracked, but also so that if they can be addressed just the same as if you hadn't trialed, whatever the gold standard of treatment is, that's something that sort of needs to happen, again, if at all possible, if resources permit. There is a clause that no one is forced into any provisions. All of the means of remedying the suffering need to be acceptable to the individual themselves. And there's been some discussion around sort of how much do you have to have trialed, what constitutes reasonable sort of attempts to remedy the suffering through approaches available. So as Annette said, the scrutiny being given to these cases is more intense than is in place for particularly track 1. Track 2 patients, often they are more complex and they have been given more scrutiny as well, but there hasn't been a formal process that sort of forces that degree of scrutiny the same way as what is being proposed. And it hasn't gone through all the approvals at Nova Scotia Health yet, but what's going forward from the working group. So it is very attentive to exactly the sorts of concerns that have been raised here. And we also had Alex Stratford, who is, I assume, well known to folks in the audience as part of the discussion as well, particularly around structural vulnerability. So there's been certainly that sort of awareness of the need to have that understanding, and while also recognizing that there's been a long history of failing to recognize the autonomy and self-determination of people who are living with mental disorders, and not wanting to go so far as to then sort of reiterate or reinstantiate some of those senses of, with immediately with a diagnosis of mental disorder, that then you are then sort of stripped of your rights to autonomy. So again, it's trying to, again, balance all of these very real, very significant values, concerns in practice through the processes that we've developed.
Thank you. And lots of conversation also in the chat. And I know our time is running short, but it's important for us to reflect. Ethics consults and ethical concerns are the bridge between policy and practice. And in that bridge between policy and practice, there's often a big gap. And that gap is where subjectivity comes in. That gap is where bias comes in. That gap is where colonial imperfection and human created systems that are not yet perfect, and funding resource challenges and education challenges, and all of these things lie in that gap. And ethics is one of the ways that we bring together different disciplines, different eyes, different perspectives to begin to discuss this. Our process at the college is not yet perfect. Our process at Nova Scotia Health Ethics Network is probably not perfect because it's human, and therefore we are still trying to figure it out. And we are trying to build that bridge together and invite more people, more doctors, more other healthcare professions, patients, first voice, so that we can begin to address that. But there's so many pieces at every step of the way, whether it's Tristan's story, whether it's what Annette was saying about all of the extra people that are being brought in for different lenses. At every step of the way, there's a human. And a human is only as good as they are not subjective. That's where we need multiple perspectives. So Holly had this great question. What is treatment resistance? Is this based on the singular westernized narrative of treatment resistance that is irrespective of cultural understanding around language? That is a great question. There's so many great questions coming up in the chat. This is a much larger conversation, and looking at, for example, Scott talks about the role of psychedelics as a treatment option. Right? There's some emerging evidence, but even what counts as evidence is what is getting funded as evidence. And then do we need evidence, and what counts as that, and how does that colonial mindset fit into that? So when we talk about decolonizing healthcare, we talk about all of this. We need to begin expanding. So if there is an expansion around MAiD, there has to be an equal expansion around structural health. And that is where we have to advocate. We have to begin opening our own minds, and then we have to invite people around us to think more critically and raise more attention. And we are at the beginning of a brand new chapter, and we need all of you to join us in shining bright spotlights on ethical concerns, and then thinking as creatively as we can about how can we reduce every silo so that we can work together collaboratively to advocate for a future where there is wellness in ways that we can't yet imagine. But that's what we became social workers and healthcare providers for, right? So thank you all. Just one more ethics cafe. We hope that you'll join us for our next one, and all of our other professional development to education. Check us out on YouTube. And Dr. Warren, Annette, we are so grateful for our partnership with you, for the ways in which You are helping us begin to forge a way forward that will hopefully ensure that all of us have better options than Tristan experienced it when he was here. So thank you, everyone, and have a wonderful day. Love you.